Talk is a workup of non-infectious posterior uveitis. Dr. Reesha is a UV and retina consultant at Little Flower Hospital. Over you to Reesha.
Okay, good evening. After anterior and intermediate uveitis, we are going more posteriorly. Next is approach to autoimmune and uveitis. Okay, most of the time after several OP visits and several investigations, most of the investigations, costly investigations, our patients ask this question, Doctor, what is the cause of my uveitis? And answer in our mind will be, don't ask me, no matter what causes it, I'll treat with steroids. But is it so? Why it is important to identify the etiology of uveitis? Because infection remains a common cause of uveitis and prompt diagnosis is very critical so that appropriate antibiotic therapy can be started on time. Considering an immune etiology and starting immunosuppressive therapy can exacerbate an underlying infection that can lead to blindness and rarely even death. So all uveitis workup will start with a good history taking. A complete history is crucial to the diagnosis and management. Onset and progression of symptoms, course of treatment should be, details should be received. Past ocular history includes recurrent attacks of uveitis and previous response to treatment. Apart from the review of systems, social history, pets, dietary history, sexual history, and drug history should be obtained in detail. For example, this patient presented with an endophthalmitis-like picture, a severe fibrinous reaction, hypopyon, but he gave a history of recurrent episodes prior in either eye with morning neck stiffness and low backache. So the diagnosis is very easy. He was treated with intensive intensive topical steroids with cycloplegic agents, and this was the picture after treatment. That was a case of HLA-B27 associated uveitis. Next comes physical examination. A patient with pan uveitis, bilateral with hypopyon and vasculitis. On examination, patient had oral ulcers, like aphthous ulcers like this. So the diagnosis is again easy. And he also had genital ulcers and GI symptoms and arthritis. So the diagnosis here is Behçet's. Lab findings include raised ESR CRP and HLA-B5 or 51 may be elevated. Your rheumatology friend may help you in further managing this patient. Next comes another pan uveitis with exudative RD and disc edema. Patient had alopecia and vitiligo. Here the diagnosis is VKH syndrome. Another young lady presented with occlusive vasculitis. She had malar rash-like picture. So that was an occlusive vasculitis of SLE retinopathy. Next comes an ocular examination. A meticulous slit lamp or indirect examination is a must for a uveitis workup, and that should be done every visit thoroughly. For example, this patient, it's very clear that it's a granulomatous anterior uveitis. Fundus shows pars plana exudates and choroidal granulomas. So that was a case of sarcoidosis. Patient had raised ACE and HRCT showed hilar lymphadenopathy. Examination of other eye is also very important because it's a case of sympathetic ophthalmia. The presenting eye had a bilateral granulomatous pan uveitis, but other eye shows evidence of old trauma. So the traumatized eye is called exciting eye and non-injured eye is called sympathizing eye. Next comes to vasculitis. The common type of vasculitis is eels, including vasculitis including veins, mainly known as periphlebitis. It can be autoimmune etiology or it can be hypersensitivity reaction to tubercular protein. Next is serpiginous choroiditis. As the term describes, it has a peculiar pattern starting from perijuxtapapillary choroid, an amoeboid extension mainly extending from peripapillary area. A slow progression is noted most of the time, associated with minimum vitritis. And always exclude infectious cause. Sometimes history may mislead you. For example, this patient was non-case of vaginous granulomatosis on chronic immunosuppression, but fundus shows retinitis patches, and on investigation came to be CMV positive in PCR examination. So that was a case of CMV retinitis due to immunosuppression. And as mentioned earlier, peripheral fundus examination is very important so that we won't miss an underlying infectious etiology. And do not miss an active inflammation. Here comes the role of ancillary investigations like FFA in VKH. Also EDI OCT, it's a non-invasive modality of investigation which gives an idea about the activity of the disease following treatment. And fundus autofluorescence helps in detecting early recurrence of a serpiginous choroidopathy. FFA gives some clues regarding the extent of the disease, like in Bassett. FFA gives typical fern pattern, so the diagnosis is easy here. And always do not forget about masquerades by obtaining biopsy. Here it was a choroiditis mimicking picture, not responding well with steroids, and later biopsy was proven as intraocular lymphoma. And if indicated, do not hesitate to use steroid sparing agents. Even though the mainstay of therapy remains still corticosteroids, but after a short course of corticosteroids to control acute severe inflammation, treatment should be started with long-term immunosuppressants. Primary immunosuppression is indicated in certain conditions like Behçet's, serpiginous, sympathetic, birdshot, and VKH. Consider sustained release steroids like Ozurdex in conditions like chronic CME in pars planitis. And also think about non-uveitic conditions. This was a choroiditis mimicking picture, but later turned to be multifocal CSR. So investigations helps in some special conditions. And what to do after all investigations, still not getting a diagnosis? Discuss with your friends. It may help you in getting more ideas. So the 10 commandments are proper history taking, physical examination, ocular examination, exclude infectious cause, do not miss active inflammation, do not forget about masquerades by obtaining a biopsy. If indicated, do not hesitate to use steroid sparing agents, consider sustained release steroids, think about non-uveitic conditions, and last, discuss with your friends. Thank you.
Thank you, Reesha. Any doubts from the madam?